Welcome to this lunch symposium sponsored by Medtronic and entitled Expanding the Heart Team, Improved TAVI Outcomes Through Pre- and Post-Procedural Collaboration. So what is it about? I think we all agree that addressing the needs of patients suffering from aortic stenosis is not only implanting the transcatheter heart valve, and it starts from the referral, how to select the proper indication, how to refer the good patients to the TAVI center. It goes with a proper procedure, of course, a good technique, a good platform implanted. And it goes also with a good follow-up and the good solutions to follow these patients. So this is basically what this session is about, what is happening before, during, and after, and of course focused on the collaboration from TAVI centers to referral centers. So we're here a team to run this session. Vijay and I will be in charge of facilitating the discussion. Vijay will receive your questions. You can address both by the app or just standing up and taking the mic. And we'll have also Tanya Rudolph, Christoph Klein, Alessandro Beneduce, and Victoria Delgado who will share with us some insights about all those topics. So I think we can directly start with Tanya's presentation about all what is happening before TAVI.
Nicolas, thank you so much for the kind introduction. And I was asked to somehow answer with my short presentation who is the best or who is a candidate for TAVI. And of course, if we ask ourselves this question, we always look at the guidelines first. And what they actually currently tell us that if we have a patient who is below 75 years of age and who is low risk, then this patient should undergo surgical aortic valve replacement, or if this patient is unsuitable for transfemoral TAVI and operable. If we have on the other side a patient who is older than 75 and is suitable for transfemoral TAVI, he should undergo TAVI. Or if we have a patient who is unsuitable, high risk for SAVR, then we should also think about a TAVR in this patient. So as you all already aware of, the guidelines are pretty old. They have been published in 2021. And of course, there is a bunch of evidence we encountered so far during the last years. So I would like to share with you some key data on that. Of course, we had last year the publication of the 5-year follow-up of the partner trial. Patients included had a mean age of 73, so below the age recommended by the current guidelines. And as you all know, TAVI was not inferior after 5 years as compared to surgical treatment. And pretty much the same data evolved from the Evolut low-risk 4-year follow-up, mean age here again, low-risk cohort of 74 years, and after 4 years, TAVR was non-inferior to surgical treatment. And then just recently published the data from the DEDICATE trial. This was a little bit different because it did not only include patients with one platform being treated during the TAVI procedure, was a different kind of platforms. Also patients who were enrolled were low risk, mean age of 74. And here we actually saw the design was also non-inferiority. TAVR was non-inferior to SAVR, but you can clearly see that the combined endpoint of stroke and death occurred almost twice as many times in SAVR patients as compared to TAVR patients. And so I think taking this evidence into account, of course, we have to ask ourselves the question, is still the guideline what we should use? And here I would like to bring up also the polling question to you. Maybe we can show the polling question and ask you, would you lower the age limit for TAVI in the next guidelines if you could? And I think it will be really interesting to get your thoughts about that.
Yeah, so you will see these polling questions appearing in a few seconds on screen, and as you know, you can reply or vote through the app, the PCR app, going to the room Mayo and posting your vote about that. While you have this over there. Maybe Tanya, what could be interesting to interpret the outcome? And I would like to ask to the audience, please raise your hand. Who in the audience is in an interventional cardiologist working in a TAVI center? Okay. And who is working in a non-TAVI center, referring his patient to TAVI centers? And now let's have a look at the poll. So, yeah.
So very interesting. 43% say they have to reduce the younger patients in the upcoming guidelines. Oh, still people are still voting, so let's maybe give a minute or two, perhaps.
And it's true, while waiting for the final outcome, Tanya, I don't know if it's something you have in your practice, but what I often see in mine, at least in south of France, is that the referring cardiologists are going faster than the guidelines, because they tell us they see the benefits during the follow-up of a TAVI for a patient. So they're asking for TAVI for younger, low-risk patients, but faster than what the guidelines recommend.
Yeah, definitely. I mean, I absolutely have the same experience that we even see patients being 60 or 65, and they already come to us with somehow having in mind that they might be treated via a transfemoral approach. And then, of course, it's even more difficult if this is not appropriate in this patient to convince the patient then that surgical aortic valve replacement is the better choice.
So for sure, we have to have more data to support that. But you heard probably, Tanya, that we had the notion too, the data presented this year at EuroPCR. What does it tell to you, put in perspective with this question?
Well, I still think that that definitely I mean, what we also learned from the US publications, that if we go to 2 younger patients, then they would definitely survive their valve, and we need to have a good concept what we're going to do when they come back. And this is an issue I think is not completely resolved yet. But on the other hand, I think if we get more evidence in that and we get more secure, then it might be really good to offer also younger patients, a little bit younger patients, an initial transfemoral approach.
Yeah, I think we can summarize maybe this, and mainly also for our colleagues working in non-TAVI center and sending their patient to TAVI centers, is that okay, we agree that we have short and mid-term data reassuring regarding safety efficacy for TAVI, for those young patients, but remember that they will outlive their first prosthesis, they will need reintervention. So therefore, maybe don't go too fast. And when you send your patient to a TAVI center, send your patient to this tertiary center saying, okay, you're going to meet a heart team who will decide what is the best treatment for your aortic stenosis.
Yeah. Absolutely. And I think this is important here to think about what needs to be done as a pre-workup to decide whether the patient should undergo SAVR or TAVR. And of course, the first thing is important, the clinical history. So you have to ask for the symptoms and also get the knowledge about the comorbidities. And then, of course, the key thing is the transthoracic echo to secure the diagnosis of severe aortic stenosis. And this usually happens in a referring center, so they already tell the patient, okay, you have an indication for an aortic valve intervention. And then usually, I mean, at least in my practice, what also usually happens in the referring center, the further workup regarding checking if the patient has coronary artery disease. So in most of the cases, the patient undergoes a coronary angiography, but of course, and we might also discuss a little bit on that, coronary CT scan might also be sufficient, at least in a certain percentage of patients. And then I think it comes to the main thing that we need to do in all the patients to really get a clear answer, and this is the CT scan. So, and this is a special ECG-gated multi-slice CT scan, and usually this is done in the TAVI center, and here we get a lot of information out of the scan, so about valve anatomy, dimensions, calcification patterns, coronaries, aortic dimensions, and if we see a valve like this, tricuspid symmetric calcification, then it's a good candidate. candidate. But if we see something like that, so highly calcified valve, LVOT, calcification, asymptomatic calcification pattern, then it's somehow a red flag for an interventional treatment. And basically also what we see with the CT, the anatomy of the whole aorta and the iliac arteries, and so if there is nothing to worry about, then it's a good candidate for transfemoral approach. But if we see calcifications, narrow arteries, tortuosity, this is also a red flag. And so just to summarize this, so usually at a non-heart valve center, the patient gets the echo, the workup for the coronaries, of course the indication, and then it's sent to the heart valve center undergoing CT scan. And I think this is a very important step for the patient, because at this is actually the stage where we can really tell what is the best approach. And then we need to discuss this patient in the heart team. It should at least be an interventional cardiologist, a cardiac surgeon. But in some patients, we also might need a heart failure specialist, electrophysiologist, or geriatrician. And then we recommend something to the patient. But then, of course, we have to take into account also what the patient thinks about. And so I think the shared decision making is here also an important point.
Thank you, Tanya. PJ, any question from the audience?
No, we haven't got any questions on the... Oh, we do. Do you also ask for dental care before TAVI? It's a very practical question.
Yeah.
Yeah, and especially in old patients, I think if really people tell you that they have somehow problems, dental problems, then you should definitely send them before to a dentist.
Yes.
Maybe one question to you, Victoria, about this. We know that it is currently questioned by studies, but very practical standpoint. When you receive in your heart valve center an 83-year-old patient that is said asymptomatic, severe aortic stenosis, but that has reduced his daily activities, but difficult to balance between age and the consequence of ES, what is your behavior?
I think that there you need to be very incisive and very persistent in the questions and make sure that the patient is truly asymptomatic, because these patients may have other problems that make them walk less. And if they are not going to be able to go into a treadmill test or a bicycle test, just make them walk in the hallway and see how they react, because you can see that maybe those 6 minutes walking distance is going to be much shorter than what would have been expected. So those are easy things to perform. And then you have as well the biomarkers, such as, for example, BNP. Of course, that these patients may be also hypertension or may have atrial fibrillation. But then I wonder really if we need to wait for the symptoms to appear, because there is already a damage in the heart. And eventually, any intervention that you want to perform, you want to make that this patient returns as much normal as possible.
PJ.
I think.
Yeah, thank you, Victoria. We have a question from one of our colleagues in the audience. Do you support the adoption of TAVI in centers without on-site cardiac surgery? This is a very frequent question that comes up every time we discuss this.
It absolutely is. I mean, I think no matter where you perform the TAVI in the end, I think it's really important to have the heart team discussion and really evaluate on an individual base the pros and cons of every approach, and you really talk to the patient. And then, of course, it's always a trade-off. I mean, to give access to the patients, adequate access, and I think there is a big difference in various countries in Europe. But I think one important point is always also complication management. And even though TAVI is a standard procedure, we all know that there might be a complication coming up. And if this is a perforation, for example, then the only chance to rescue this patient in this situation is if you have cardiac surgery on site.
Very clear. Yes, please.
Hi, I've got actually two questions. One is this, that the age for it, do you think it should run by different continents or different countries as per the life expectation as well? Because some countries' life expectation is way lower than the Europe. So do you think just generalizing it might not be that much of an essence to the rest of the places? The second thing is the heart team discussion. So during heart team, everyone is there except the patient. So we decide about the patient, and then we meet them separately. Do you think there should be a concept where you could just invite the patient for your heart team as well, or not?
Thank you. Two very important questions.
Exactly.
First one.
Yeah, first one. So I definitely think you are right. Age is just a number. So I think it's more important to look at the life expectancy of every single patient and discounts in the end. I mean, that's pretty clear. And the other one is, you are right. And as I've shown here on the picture, I personally think that it's better to be together with the surgeon, cardiologist, see the patient and discuss the options, because it's different what you tell them if you are just somehow apart.
Thank you.
Okay.
Yeah, you had something else to share with us, I think.
Yeah, I just was asked to give a brief details on gender differences as well, and we are all aware of the fact that even though the incidence is the same, male patients get treated more. But of interest, if females are treated, then they usually get a transfemoral approach. And we just saw in a recent analysis from the National German database that if a female patient undergoes TAVI, actually they are doing better than their male counterparts. And this has been published in other sources as well. But we have to be aware that female patients are undertreated. And we should also take into account that if they are treated, their outcome is better. And from the current publication of the SMART trial, somehow we also got new information that even if we treat the patient with a TAVI, the platform might also somehow influence the outcome of the patient. I think this we have to follow up in the future, how this impacts the outcome if they're long term.
Yes.
Thank you very much, Tanya.
Thank you, Tanya. So I think I really want to dwell a minute on the sex differences, because aortic stenosis, obviously, it happens if we can say equally in both men and women, and there are differences. There are differences in the way they present. Women have more dyspnea when compared to men, so maybe they present with something different symptom. They might be told nothing wrong with you, and I'm really shocked to read data that women get even less echocardiography. So if you don't pay attention to the symptoms, if you don't pay attention to doing the basic investigations like echocardiography, how are we going to diagnose the condition? How are we going to provide that? So maybe you can comment on that, how we can overcome the barriers, Tanya.
Yeah, well, I think it's important that auscultation, I think, a very basic thing we should promote on that for general physicians, because like this you could easily pick up that there might be something wrong with a valve, and then people just should be sent to a cardiologist right away.
Yes, so it's raising awareness. Yeah, could something, or even just listening to the chest, and that's
Absolutely.
not happening.
Yeah.
People are into all kinds. So if you listen to the chest and you identify the murmur, send them to echo, that's going to pick up. And if the patient fits in with the current criteria, then they should be sent to the TAVI MDT team for discussion regarding the intervention. And obviously we do have, the SMART trial was absolutely fantastic, focusing on female patients, majority were women. And are people concerned about procedural complication? Is that why there is maybe a sort of a hesitance for offering? Because you're showing that TAVI outcomes are better in women.
Yeah. So I think even though the periprocedural complication rate is a little bit higher in female patients due to smaller arteries, usually it should not withhold you from treating female patients.
Yeah. And obviously paying attention to the procedural aspects, particularly the access. And women tend to bleed a lot more, and of course if we pay attention to that. And you mentioned about just focusing on the MDT aspect. So, it varies across the board. In my institution, we just say bring everybody in and we'll do the investigation. So if people don't have the opportunity to do CT angiography, CT evaluation in the district hospital. So I guess it's kind of adopting what works best for their institution and for their patients.
Yeah, absolutely.
And we don't often have geriatrician in our in our MDT. So how about you? Do you always have geriatricians?
No, so usually it's the core team is the cardiologist and the surgeon, but I mean in some cases it might be helpful to involve other specialities to get the best for the patient.
Yeah, absolutely. Brilliant. Thank you very much, Tanya, for your excellent presentation. With that, now we'll move on to our next presentation, which will be provided by Christoph Klein. So, of course, what should focusing on the valve designs and the procedural refinement. So you're going to talk us through that.
So thank you very much for the kind introduction. Yes, I would like to kind of focus on what kind of, when it finally comes to the intervention, we have to think of. Because Tanya quite nicely showed that you do CT analysis and you look at some of the features of the CT and see if a TAVI is feasible or not. And some of the things, when you come to younger patients, it's not just if the procedural first outcome is going to be good, but you have what is kind of in the world for several years now, it's the lifetime management. And of course you need to consider the age, you need to consider if the patient has coronary artery disease. You definitely want, for example, to secure coronary access in the future. LV ejection fraction, do you want to use an implantation strategy to avoid left bundle branch block or pacemaker disturbance implantation? You know, the size calcification, LVOT, how far oversizing you can go of the annulus compared to the LVO OT. And of course, when it comes to the coronaries, the height, eccentricity, you want to consider if a future valve-in-valve implantation might be feasible. So this is what you all have to take into account when you actually make the decision. Now, I think commissural alignment is now, especially for the supraannular valves, an absolute must. It's fairly easy to understand that you want to preserve coronary access, especially when the patient already has coronary artery disease, but they can develop this. And, you know, you don't want to leave the patient going to another hospital with something like this, where the post of the prosthesis is right in front of the coronary ostium, and then it will be very difficult actually to selectively image and even do interventions. So this is important. Also, it's important for future valve-in-valve procedures. For example, if you want to do leaflets modification, you know, like the basilica technique, where when the leaflet might, the ostium might be at risk of to be occluded by the leaflet, you can only, the split in the leaflet only helps, you know, when the leaflet is in front of the coronary and not when the post is in front of the coronary. Then basilica doesn't make sense. So this is what you need to consider when you choose your valve and also your implantation. The next thing that I think is also important is that you want to reduce left bundle branch block and pacemaker implantation. And of course, there is some patient characteristics that predispose this patient for this kind of complications. It's pre-existing conduction disturbances. And we know also the valve type, so the core valve platform is more prone to have a pacemaker implantation than a balloon expandable. But the implantation depth is important. And hopefully in the future, we're going to have computer models that will tell us which valve in which kind of height of implantation and implantation strategy will have certain risk for paravalvular leakage or, for example, for pacemaker implantation. So now my task was to talk about the Evolut FX system, which is fairly new, and it is kind of the follower of the Evolut Pro Plus system. And they have made some changes along the whole way. They redesigned the tip for better vessel introduction. They have redesigned the capsule and the shaft for better flexibility to maneuver through the body vessels. And for me as an implanter, it was very important that they optimized this stability layer so your implantation becomes more stable. And additionally, they have introduced some markers below, and I show you what they might be for in just a second. So this is kind of an implantation, the idealized implantation, what you can see when you retrieve the capsule and you deploy the valve, it stays very stable compared to the former system where it used to kind of dive into the ventricle, and then you had to start further up and you had to pull maybe, and it all kind of dragged the whole system towards the inner curve of the aorta. And so the angle of the prothesis compared to the annulus was farther off. So this new system addressed that problem, and we'll see if that worked. The second big thing for the implantation is these markers. They give you kind of a better visibility of where you are compared to the annulus. That's especially for elderly men. It's good because we don't see as well anymore. And the second thing is that they are placed under the commissures. So they have they give you a feedback if your commissural alignment is good or not. So let's talk about the implantation. I have brought an example of a 83-year-old gentleman with high-grade aortic stenosis, ischemic cardiomyopathy, so you definitely want to avoid left bundle branch block or pacemaker because this is not good for these bad ventricles. Multiple coronary interventions, so you definitely want to secure coronary access. The kind of valve-in-valve issue is probably at that age not that important. So CT is everything, and so you look at the annulus, you look at the annulus size. This is kind of what defines your valve size. You want to know if there's calcium, is there not calcium? There is none, that is good. You want to look at the calcium distribution of the leaflets, and they're quite homogeneous, a little bit more, a little bit less on the non-coronary, which is actually quite rare. And you look at the height of the coronaries, and everything above 10 is per se a good sign. If they are below 10 millimeters, then you have to look out if the sinus is big enough and will there be enough perfusion. Then, of course, you always also look at the implantation angle. And as you're probably all aware of, the Evolut system is implanted in the cusp overlay technique. So it's usually an RAO caudal view, and you can get all kinds of views in that. So we decided for the Evolut FX because of peripheral artery disease. We decided for a transaxially approach because in this Evolut system, the valve is always in the same orientation compared to your delivery system. It's always the same. So you can get markers on your delivery system when you introduce this system into the patient, and there is kind of this padlock, and so you put this on the flush port on 3 o'clock, and usually then you get fairly good commissural alignment. We wanted a high implantation to avoid pacemaker. So, and here in the upper thing, you see the 3 cusp view, which was kind of in the old age, the kind of the orientation that everybody was implanting their valves in. On the left side, you see the non-coronary cusp. In the middle, you see the right coronary cusp, and on the right side, you see the left coronary cusp. However, now it's the cusp overlay technique where you kind of separate the non-coronary cusp on the left side, and the right and left coronary cusp are on top of each other in that view. And that gives you a very good indication of how deep you are in the non-coronary cusp. And with the Evolut system, you have this head marker here. And if in that orientation it's in the middle, you're kind of fairly sure that your commissural alignment is good. Now at that stage, if you're not satisfied, you have to pull back the whole system to the descending aorta when you come from transfemoral to change the orientation a little bit, go back there and see again if your head marker is where you want it to be. So then you implant in the cusp overlay technique, and you have these kind of 3 spots, and you see the marker on the right side. And if you have 1 marker on the right side and 2 on the left, that kind of also reassures you that your commissural alignment is okay. And then when you pull back the cusp, you can see that actually the whole system is fairly stable. With these big valves, the 35, you have some movement because it kind of flares out. But in this, it gives you quite a good idea of where you are. And then, of course, you have to look at the implantation depth. And usually you have, when we look at it again, you have this parallaxis. So your annular plane and the procesus plane are not the same in this orientation. So you can move a little bit. Usually you go a little bit more RAO, and then you can see here in the next, you can see here, this is the non-coronary cusp, and you are definitely good. Your marker is right at the annulus level. And then you also want to know, because you have a lot of parallaxis now with the annular plane, you want to make sure that the left coronary is also under the annulus plane, and you go to a further LAO cranial projection, and then you lose control over the non-coronary cusp, but you get a good view of the left coronary cusp. And if you are happy, you can start to deploy the valve. And if you are not happy, if you're too low, too high, you can resheath and start again. And then here you deploy the cusp, but you will see that it always tilts a little bit, usually, especially with these larger valves, because it kind of wiggles itself into the anatomy of the annulus and of the ascending aorta. So it does tilt a bit, and this kind of small tilt that was more pronounced with the Pro Plus, but still you have to kind of take that into consideration. So now if you go back to the cusp overlay orientation, you can reconfirm that your 1 marker is on the right side, because that's one of your where one of the commissures is, and your 2 other markers are on the left side. And if that's the case, your commissural alignment is okay. However, you don't have a chance to change that anymore in this at that stage. And then when you do your coronary angiography, you can see it's a quite high implantation, and this is the 3 cusp view, so all the 3 markers are next to each other how it should be. There's hardly any paravalvular leak, so it's a good result. The echo shows no insufficiency. There's a median gradient of 5 mm mercury, and there's no real ECG change, which is important. And kind of this, what I demonstrated, it is also was shown by a very early American study where they looked at the FX system, and they could actually demonstrate that the commissural alignment rate is in the above 90%. So that's very good. So all the other kind of complications are in the normal range. The pacemaker rate was still a little bit high of almost 12%, and the kind of here the commissural alignment is good. However, when you look at the depth of the non-coronary and the left coronary cusp, it is always, or most of the time, it's the case that the non-coronary cusp, the implantation depth is a little bit less than on the left coronary, but that's kind of what you expect and accept. So there's this one study, a CT study, looking at of how the commissural alignment is, and they looked at the FX system, and you could see this is none and this is mild, up to 30 degrees, which is acceptable, and it was only that 6.5% were actually not aligned to the commissures. However, in the beginning, there was one image where you could see that the coronary is not always in the very middle of the sinus. So there is an eccentricity sometimes, and so whenever you think of a valve procedure in the future, you might have to consider that the pure commissural alignment might not be enough. Last slide, a new type is going to come out, and it has been implanted in the States, I think, this Monday, and it's the FX Plus, where actually you see the metal struts have been removed where the coronaries are in the middle of the commissures, so that will even give us probably, most likely, a better access to the coronary arteries. So, heart team, look at the CT, implantation strategy, lifetime management. This is an important part. The FX system addresses some of these problems and is a definitely improvement in terms of alignment and implantation depth, and it's a further step into the improved results in lifetime management. Thank you very much.
Thank you. So thank you very much, Christoph. I think we can summarize and rephrase what you perfectly demonstrated, is that this new FX platform allows for a better accuracy regarding the implant depth that has a relation with the amount of PV leak and with the pacemaker rate, which are two important outcomes. And it also allows for a better commissural alignment that will make the coronary access easier for the future lifetime management of a patient, and may, let's see, have also some benefits regarding the valve function. So it was very clear. Thank you very much, Christoph. And this is what happens during the procedure. And now, again, thinking about the journey of a patient, we would like and we wanted to discuss with you what happens after the procedure. Again, still being in the shoes of the cardiologist who will be in charge of a patient after the TAVI procedure. And one of the major aspects related to that is the need sometimes to perform the coronary access or PCI after an Evolut implantation. So please, Alessandro, tell us about that.
Thank you very much for the kind introduction. So we're going to focus on coronary access and PCI, how to be proficient at it in a practical way. So when we talk about coronary access and PCI after TAVI, we talk about the spectrum of complexity. It could be a very easy task, or it could be a challenging one. And what will make the difference is your knowledge about the factors, the anatomical and procedural factors that affect coronary access after TAVI, but also your knowledge of the valve. Particularly, I'm referring to all those features of the valve that are relevant to this task. For example, the frame cells, which represent the opening of the frame that you're going to use to access with your catheter to the coronary sinus. But I'm also referring to all those tissue structures, such as the commissural post, the supraannular leaflets, or the sealing skirt, which represent the barriers to coronary access. And among these barriers, the position of commissural post, as Christoph previously mentioned, is absolutely important, because if you are in a situation of dealing with a valve that was implanted, as Christoph did with commissural alignment, meaning that your post will match the position of the native commissures, then the access to the coronaries will be clear. But if you end up in another situation of commissural misalignment, coronary access might be more challenging. So one of the first things that we could do is try to understand how to figure out if this valve was implanted, the valve you're dealing with was implanted with commissural alignment or not. And how can you do this at the first glance? So the problem is that your structure of interest, the commissural post, is not visible in fluoroscopy. But as you saw, there are some markers that highlight this position. So if you look at the top of the frame, the C-tab, which is common to all the Evolut platforms, marks the position of a single commissural post. While if you're dealing with an Evolut FX, you will also find these markers, these three markers, one for each commissural post at the bottom of the frame. And now the task is, how do I use these markers to understand where the valve is implanted with commissural alignment or not, especially if the procedure was performed in another center. So one tip, very important, is go in a projection that isolates one of the coronary cusps. For example, the iliocranial is the easiest thing to do. It isolates the left coronary artery, and look at those markers. If you see the C-tab at the top of the frame pointing towards the right side of the screen towards you, or if you see two markers overlapping on the bottom of the frame on the right side of the screen, you know that your valve was implanted with commissural alignment. Now there is another preliminary consideration that we should do is the vascular access. In general, you should go for a femoral axis or for a left radial and prefer those axes over the right radial because they will give you easier access to the Evolut frame and easier manipulation of your catheter. So now what I'm going to do is I'm going to give you a practical step-by-step approach to perform coronary access and PCI after TAVI with the Evolut platform. And I'm going to do that by using some brand new contents that we created specifically for this symposium. So the first step, understand the anatomical scenario you're dealing with. How to do that? As we said before, go in a projection that isolates one coronary cusp. For example, aleocranial that isolates the left coronary cusp. Advance a pigtail catheter in the upper third of your valve and perform an angiogram. You will get a lot of information. First, focus on the anatomy. You can look at the shape of the aortic root, at the position of the coronary ostium, at the angle of takeoff of the coronary artery. Then you can focus on the valve. You can have information about implantation depth. You can look at those markers that we saw that will alight the position of the commissural post and make you understand whether you are in a situation of commissural alignment or not. But also try to figure out where those tissue parts that are the barriers to coronary access actually lay. And keep in mind that they are not visible in fluoroscopy. And finally, try to visualize which is the target area of the frame that you want to access. Now, the next step is the selection of the catheter. It is very important to deal with what you have in your cath lab, clearly, but in general, I would suggest you that for a standard case, you go for a Judkins left or a Judkins right. And in case of smaller or effaced aortic root, you select catheters with a smaller turning radius, particularly for the right coronary artery, which is probably the most challenging to access. For example, the Williams right or the internal mammary, while if you're dealing with a capacious or angulated root, you could select an Amplatz right or an Icari catheter. And the reason behind that is that what you really want, what you ultimately want from your catheter is to really give you the chance to perpendicularly cross the Evolut frame and coaxially approach coronary ostium. And another important tip is downsize your catheter. It's very important. And don't be afraid of using a JL catheter. You will get support from the Evolut frame. Now, the next step, once you have your catheter, is to approach coaxially the ostium. So what you do is generally you advance a J-wire through the valve frame. It's very important that you make sure that you pass through the center of the valve frame. You can advance your wire in the LV if you want, and then you pull back your catheter above this barrier of the leaflets, and then try to select the correct cell to access the frame. If you're not happy with the position, you can always use your J-wire to try to redirect your catheter in the right cell that will allow you to have a coaxial access. Now, to summarize this step, first of all, select the cusp of interest with your J-wire, help yourself to adjust the position of the catheter with the J-wire, and then go straight to target right cell. Once you've done that, you can engage the ostium and go for PCI. So if you are in this situation where you have managed to have a good selective coronary access, then it's quite easy. I guess you just advance your guide wire and you stand and you performed your PCI in a standard fashion using a standard technique. But on the other hand, if you're dealing with a situation like that in which you access the sinus but you're not able to get a selective engagement, well, don't struggle, just pause, hold the position and use this technique, which is called the fishing wire technique. It will allow you to easily advance a wire into the coronary artery. And when you've done that, you can go with a balloon and advance over this balloon a guiding catheter extension to selectively engage this coronary artery, and then you could easily deliver your stent and perform your PCI using an advanced technique. So once your PCI is finished, you have to disengage and you have to do it safely. So the way to do that, no matter the technique you selected, either standard or advanced technique, is always try to withdraw your catheter over your guide wire. It's very important to not get entangled in the Evolut frame. And so to summarize, these are the 5 key steps for a proficient coronary access and PCI after TAVI with the Evolut platform. And if I could give you my take-home messages, first of all, know your valve, know the valve you're dealing with, select the proper access size, try to take advantage of these fluoroscopic projections that isolate the coronary cusps, select your catheter according to your needs. Generally, you could try to go first with a PCI catheter, because once you struggle, for example, to get a position, then you don't have to change the catheter if your PCI is needed, and then master the standard and the advanced technique. Thank you.
Thank you.
Yes,
Thank you, Alessandro. Very clear, and I would just add to your talk the fact that, and it's just sharing experience here, but what we are doing, respecting all the steps you mentioned, is that even for diagnostic coronary angiogram, we're using guiding catheter because it allows you for more important injection, more contrast injection. It allows you to inject while having a wire to reposition and change from a cell to the other cell. So even if you're not perfectly engaged in a coronary osteum, you still have a good visualization. I see that we have a question about the oral medication, but what we can do, maybe Vijay, is keep this for the next talk and for Victoria, because it will be maybe more related to what she has to tell us. So thank you very much, Alessandro. Vijay, you want maybe to introduce Victoria?
Sure, yes, absolutely. So it's really fantastic. We are hearing about access, and we talked about low-risk patients. But how about younger patients? You know, we not infrequently we see young people coming in with aortic stenosis, and of course the question of durability, how long the TAVI lasts. So Victoria is going to tell us all about it. Thank you, Victoria.
Thank you very much, Vijay, and thank you very much for inviting me to this very interesting meeting, where I'm not an interventionalist. I practice in a center where they do TAVI, but I consider myself a referring, so it's very useful, all this information that you are sharing, in order to discuss with the patient which procedure to undergo and which valve to implant, because the audience has accompanied us very well, sharing their opinions about, do we need to reduce the age threshold to perform TAVI, or do we need to bring the patient to the heart team? Maybe we don't have to bring the patient to the heart team, but for example, one thing that I used to hear sometimes is that the patient will get the valve that I say. And this paternalistic approach is something that we need to abandon and discuss with the patient the pros and cons and the available solutions that we have. So this is basically what we need to discuss with the patient when we come into durability. Know which is the native valve disease that we have, we know which is the initial intervention that we may have, and which is the subsequent intervention that the patient may undergo if there is a failure of the prosthesis. So if we go to the lower range of age, for example, there we can see that the earlier we start with a biological valve, perhaps we are going to need earlier a change of that valve or an intervention of that valve. While if the patient is rather old, maybe we don't need any other second intervention. So that's something that we evaluate in these patients and we keep in mind based on the literature that we have. Now, comparing surgical versus transcatheter aortic valves, we have the NOTION trial data showing already the 10 years follow-up and showing no differences in terms of the cumulative incidence for more than moderate structural valve deterioration. But for severe structural valve deterioration, it seems that TAVI valves perform much better than surgical valves. And the definition of severe structural valve deterioration is a mean gradient of at least 30 millimeters of mercury and an increase in mean gradient of at least 20, or a severe intraprosthetic aortic regurgitation. Going, for example, to the comparison of the PARTNER 3 and the low risk Evolut trials, you can see that for the PARTNER 3 at 5 years of follow-up, there were no differences between surgical and transcatheter prosthesis for stage 2 and 3 structural valve deterioration, while for the Evolut, the low-risk Evolut, there was a much better durability of a significant better durability of the transcatheter aortic valve rather than the surgical aortic valve, considering that there were different platforms used in surgical aortic valve in this trial. If we go to the studies that have compared the different platforms that we have for transcatheter aortic valve implantation, you have the UK TAVI registry, where you can see that at 12 years even follow-up, you can see that there is better durability perhaps of the self-expandable core valve. And in the case of the choice trial, for example, at 5 years follow-up, there were no differences. And in terms of the comparison between Accurate Neo and the SAPIEN 3, for what concerns structural valve deterioration with at least moderate hemodynamic valve deterioration, it seems superior perhaps for SAPIEN, and there are other complications that we need to keep in mind, such as valve thrombosis or endocarditis. So, how do we foresee these complications? And we don't really have many data to understand at baseline who is going to degenerate in a way or the other. We have this simulation study where they try to understand how will be the evolution of the patients that are treated initially with a surgical aortic valve replacement or with a transcatheter aortic valve replacement, and taking into consideration a lifetime span of 40 years of follow-up. So this is a rather complex table, but if you bear with me, here what we have plotted is the event time ratio. And we have the life expectancy gain, and we have in blue here the surgical aortic valve replacement, and in red the transcatheter aortic valve replacement. So this event time ratio means how much durable or how much similar the durability between a transcatheter aortic valve is with a biological surgical aortic valve. 0.1 would mean that the event time ratio for the valve failure is 1/10 of the one of surgical biological prosthesis, while if it closes or is closer to 1, the durability between the transcatheter aortic valve and the surgical aortic valve is quite similar. Now, you can see that more or less at 0.6 and even time ratio of 0.6, the transcatheter aortic valve replacement starts to impact a little bit on the life expectancy gain, but in this model, it will be really impacting when the event time ratio is less than 0.3. So the gain in lifetime expectancy was higher with an index or making the patient undergo first a surgical aortic valve strategy. If we have a higher event time ratio than 0.3 and we start with a transcatheter aortic valve replacement procedure, you will see that for a model time horizon of 40 years, the first reoperation will be in 81% of the cohort, that will need one reoperation at 10 years. A second reoperation will be at 56% of the cohort, and a third reoperation will be at 31% of the cohort. So in a way, it would be a rather good durability, and we need to keep in mind which is the first valve that we implant, how is the alignment with the commissures, how is going to be the access to the coronary arteries, and later on as well, what will be the hemodynamics of those valves. And in this graph, it comes the event time ratio plot against as well the different age of the patients from the 40 years to the 80 years. And you can see that here that will be favoring surgical aortic valve replacement. So if we take the 0.3 event time ratio and we implant this transcatheter aortic valve replacement, it will be almost similar than implanting a surgical aortic valve replacement for an age of 70 years or older. So kind of answering the first poll that we had where people were looking forward or at least were willing to consider reducing the time threshold to 70-year-old. It's very important to keep in mind how is the definition of bioprosthetic valve dysfunction, and this is coming from the Barfi criteria when you have stage 1 with a morphological valve deterioration with a structural valve deterioration or non-structural valve dysfunction, which is other than paravalvular regurgitation or patient-prosthesis mismatch, and includes as well thrombosis or endocarditis. Stage 2 will be moderate hemodynamic valve deterioration, which includes the structural or the morphological valve deterioration and at least an increase in the mean transvalvular gradient of at least 10 millimeters and resulting in a mean gradient of at least 20 millimeters of mercury. But keep in mind that it should be an increase, a change in that gradient, or there is a new occurrence of more than 1 grade intraprosthetic aortic regurgitation. And stage 3 would be the severe hemodynamic valve deterioration with a morphological valve deterioration in stage 1 and an increase in mean transvalvular gradient of at least 20 millimeters of mercury, resulting in a mean gradient of at least 30. And also then you have the aortic valve area and as well the new occurrence of aortic regurgitation. Now, this is an example of an 81-year-old female with an annulus rather small, 20 millimeters, and with severe aortic stenosis, so it was implanted with Evolut. And at 5 years, you can see that the gradients remain the same. And in terms of the function, if I compare these 5 years with this initial at baseline, it seems that has improved, which could have impacted as well in the gradient if we would see an increase of the gradient, but in this case remain similar. The data that we have now comparing the self-expandable versus the balloon expandable valves for patients with small annuli, it has been published in the SMART trial, showing that for the balloon expandable, the mean gradient is a little bit higher and with a slightly smaller effective orifice area. And in terms of hemodynamic structural valve deterioration at 1 year, it seems that the balloon expandable had a higher incidence of these events. But again, keep in mind how we assess the hemodynamic evaluation and the gradients, because they are dependent on how is the flow status of the patient, how is the changes of ejection fraction, how is the dimension of the ascending aorta, where you can see that these patients with smaller aorta may have higher gradients, how are the loading conditions of the patient and the aorta stiffness, and these need to be put into the equation as well to understand the results. So I think that these are very important data from which we will get new knowledge and will help us into the decision of which procedure undergo and which valve to implant. So I think that there are robust data to inform our patients about the durability of the surgical and transcatheter bioprosthesis, to facilitate the discussions about choice of valve and not just saying the patient will get the valve that I want. And in women, small annulus may lead to more frequently increased gradients without meaning structural valve deterioration. Change about the change in the mean gradient and the factors that may influence that change. And knowing those factors will help us also to better assess the follow-up of these patients treated with TAVI. Thank you very much for your attention.
There is thank you very much for an absolutely brilliant overview there. There is a question here. It is slightly maybe provocative. What about endocarditis in TAVI valve? And can we take the valve out? Is a question from our colleague in the audience.
So there are already data coming out from registries on the incidence of endocarditis, and we discussed at the beginning the importance of having a good hygiene of the dental care.
Yes.
So I cannot emphasize more how important is that in order to prevent any event of this complication that for elderly patients, and that is what in many countries in Europe we are treating right now, more than 75-year-old, is a very serious complication. Now, these valves many times depends on how they generate. The patient can continue with antibiotic therapy. And if there is no significant dysfunction and no indication for intervention urgent, which means heart failure, uncontrolled infection, or stroke, or embolization, you could keep the patient with antibiotic therapy and follow up the patient with a PET-CT scan in order to see how the inflammation goes and complete the antibiotic treatment. If there is any indication for intervention, that needs to be discussed with the heart team, and there should be probably a root replacement, but that will depend on the risk of the patient, the lesions that we may have around the structure, and what is going to be the lifetime expectancy of those patients.
Yeah, so it's emphasizing also the importance of post-TAVI care in these patients. They need to take equal precaution to our surgical intervention to prevent these happening. Maybe we'll quickly touch on the final question, Nicola. The anticoagulation is always a contentious question in the TAVI setting, of course, and many of our patients not only have coronary disease but also atrial fibrillation. So there is a question from one of our colleagues in the audience, what would be the anticoagulant strategy in these patients with atrial fibrillation and TAVI implantation?
So with atrial fibrillation, I think that in those patients are going to have a CHA2DS2-VASc score that is very high, and therefore they have already indication for anticoagulation. I think that NOAC or acenocumarol or whatever is the common practice in your country is these patients you need to prevent the risk of a stroke. That's basic. Now, if they have also indication for antiaggregation, you need to keep in mind that patients may have an increased risk for bleeding, and there you need to weigh the need for antiaggregation if, for example, the patient has coronary artery disease. But in that case, I will go for anticoagulation.
Thank you very much, Victoria. And I think it's time for us just to summarize what we've learned together throughout those 60 minutes. Remember, we discussed introducing the session about optimizing the needs of patients suffering from severe AS. And I think what we've heard today was quite convincing in the fact that we should, for sure, embark the referral center as part of the heart team to make sure that we maximize the chances of a patient to have a proper indication for intervention. We saw that with a technique optimization and with the latest iteration of the Evolut platform, we can optimize the outcomes for the patient at short, mid, and long term. And we see that we have long-term reassuring data regarding durability or the risk of structural valve deterioration with Evolut platform, which is very useful, of course, for the person, but also for the cardiologist to reassure their patient at the time of discussing about them, about the TAVI indication. So having said that, I just wanted to thank Medtronic for helping us to develop this session. Thank you for your participation, and thanks all the discussants and presenters for their active participation in this session. And have a good afternoon during this EuroPCR.